Friends, let's start with murmurs. Um, so here we can see there is aortic area in the second intercostal space on the right, and then there is this pulmonary area, the second intercostal space on the left, and below it we can see the left external border, and just below it, then again we can see the tricuspid area, and then there is this mitral area in the fifth intercostal space on the left side. So, what murmurs can we hear at pulmonary area? So, the murmur of pulmonary stenosis and atrial septal defect can be heard here. These are both systolic ejection murmurs. At the aortic area, we can hear aortic stenosis murmur. Right. Now, if we go on to the tricuspid area and mitral area, then in tricuspid area, we can see the systolic murmurs as tricuspid regurgitation and VSD, whereas we will see the tricuspid stenosis in the diastolic murmur. And if we talk about that mitral area at the apex, then similarly, mitral regurgitation presents as a holosystolic murmur, while the mitral stenosis would present as a diastolic murmur. Also, the mitral wall prolapse will present as systolic murmur only. Which murmurs can we hear at the left external border? And the aortic regurgitation and pulmonary regurgitation murmur can be heard here as diastolic murmurs. At the same time, we can hear the HOCM murmur here. It is a systolic murmur. So, if we talk about inspiration, so when we inspire, when there is negative pressure in the thoracic cage, which leads to the pooling of blood in the right side of the heart, which leads to more intensity of the right-sided murmurs. And the opposite would happen on the left-sided murmurs. The intensity will decrease. So now if we talk about the passive leg raise and squatting, these will again similarly lead to pooling of blood in the right side of the heart, which would lead to the increased intensity of most of the murmurs. Uh, Opposite of these will occur in the HOCM and mitral valve prolapse, hypertrophic cardiomyopathy and mitral valve prolapse. These both will decrease. And the opposite of this will happen in Valsalva and standing. So here most of the murmurs would intensity would decrease for the obvious reason, whereas the HOCM and mitral valve prolapse murmurs intensity will increase. That's as easy as gets. Now let's go to the systolic murmurs. So we have four murmurs here: aortic stenosis, then mitral and tricuspid regurgitation, mitral valve prolapse, and VSD. We talk about the aortic stenosis murmur. So these murmurs will lie in between the S1 and S2 window because these are systolic murmurs. So the aortic stenosis murmur presents as a crescendo, decrescendo systolic ejection murmur. And when there is severe aortic stenosis, it would present as pulsus parvus et tardus. Pulsus parvus basically As the severity increases, the pulse in aortic stenosis becomes weaker. When there is severe aortic stenosis, it presents with delayed peak as well. So that we talked about the pulse, and clinical features would include syncope, angina, and dyspnea on exhaustion. Now, if you see the regurgitation murmurs of the mitral and tricuspid area, then these are again holosystolic, high-pitched, blowing murmurs. So, where can we see these? So, we will see them in ischemic heart disease, and we will see the MRV. We will see in this, and we can see these both murmurs in infective endocarditis as well as rheumatic fever. Now, let's talk about mitral valve prolapse murmur. Could present as a late systolic crescendo murmur with a mid systolic kick. Okay. The cause of it would be secondary to Marfan syndrome or Ehlers-Danlos syndrome. Let's see ventricular septal defect murmur. This one is again a hollow systolic murmur, and it is a harsh sounding murmur. So when we talk about VSD, the larger VSDs have a lower intensity murmur than the smaller VSDs. Now let's see the diastolic murmurs. As we know, the diastolic murmurs are aortic regurgitation and mitral stenosis murmur. So they will be heard after S2. So it's a high-pitched blowing early diastolic decrescendo murmur, as we can see here. Also, it's, it presents it can present as a hyperdynamic pulse along with head bobbing, and it is severe and chronic. Causes of the aortic regurgitation murmur includes bicuspid aortic wall, endocarditis, aortic root dilation, and rheumatic fever. Now, when we talk about mitral stenosis murmur, it follows a opening snap. It is a delayed, it starts here. It's a delayed rumbling mid to late diastolic murmur. And when we talk about the causes, then we are talking about rheumatic fever. So it is a late and highly specific sequel of the rheumatic fever. So then when the mitral stenosis is over time, it can lead to the pulmonary hypertension and left atrial dilation. And we know that left atrial dilation can lead to atrial fibrillation and Orton syndrome. So Orton syndrome is basically when the increased volume of the left atrium causes compression of left recurrent laryngeal nerve, which leads to hoarseness. So that is Orton syndrome. So in the continuous murmurs, we have just PDA, patent ductus arteriosus. It would present in a both systolic as well as diastolic period. It is basically a continuous machine-like murmur. It is best heard at left infraclavicular area, and we know the famous cause of it is as congenital rubella.